Hi, welcome back to the channel. I'm Eugene Day. Today I want to talk about three of the biggest problems that I see facing emergency departments today from my own experience working with academic emergency departments and major medical centers in urban environments. So rural hospitals that I have less experience with may have a different set of challenges, but for most people in most hospitals, I think these are kind of the three biggest factors that inside the emergency department people really worry about and hospital administrators really worry about in terms of providing excellent patient care, in terms of local profitability, and in terms of the ability to meet the mission, that is to stabilize and provide care for patients who arrive in urgent and emergent circumstances. So the first fundamental challenge is simply crowding. Crowding in the ED means more patients that are requesting service than you have the ability to functionally serve. Now, this is typically not actually just an ED problem. Obviously, when you have a huge bolus of patients who arrive at an emergency department, that is an extraordinary challenge for the people who are seeing those patients to move them through. Each patient requires individualized care. There are a lot of things you have to do to provide care to those patients and to ensure that they're receiving what they actually need and that they are not experiencing some occult or clandestine problem that is likely to cause even more serious issues. So, for example, someone comes in with a stomach ache, you have to do a cardiac workup because sometimes heart attacks are misconstrued as belly pain. Now, crowding is a functional problem in the ED that has a lot of different causes. One, of course, is simply the number of patients who arrive. Second is the number of nurses and physicians that you have to approach and confront that challenge. Third is the physical space of your room, the number of exam rooms that you have, the ability to see patients. This is why we see patients in halls sometimes. This is why we are seeing a lot more in the way of new vertical ED treatment areas, which means that the patients can be sitting up instead of lying down, which means that they can be a lot closer together. Lower acuity patients are, generally speaking, able to be served safely and effectively in that environment. And then finally, ED crowding is also impacted profoundly by the ability to discharge patients once ready or to admit patients up to the floor and the inpatient areas of the hospital. So this is a whole systemic problem. It is not simply a problem of too many people are coming to the ED, but we do have too many people coming to the ED because the ED is also used now as a proxy for primary care for a lot of people because they can't get appointments with their primary care physicians in a timely way, especially when they're sick. So patients who maybe have a cold or who have the flu, they don't need ED care. They may know they don't need ED care, but they have no access to primary care either because they don't have insurance or because their primary care facility doesn't provide on-demand appointments for sick patients. They just don't have at-need scheduling available. The second major problem that I see in EDs today is the boarding problem. So this, of course, impacts the crowding problem as well. But the boarding problem basically is that patients who are medically ready for admission to the inpatient areas or to the operating rooms. So patients that have come in, they've been stabilized by the ED, but they are not ready to go home. They're not healthy enough to go home. They need to be admitted to the hospital or they need to have a surgery. And the hospital does not have an open inpatient bed for them or has a slow process for moving them from the ED to the inpatient areas. This is a very common problem. The result of this is that there are a lot of patients in beds consuming occupancy in the emergency department, and there is no way to use that space as treatment space for the patients that are in the waiting room. This happens in every ED in America. It's a really common problem. It's really challenging. And there's a lot of reasons for it that are very difficult to address. One is the decision-making process of where in the hospital to admit the patient. Another is the ability to get someone in those inpatient areas to take report, which means to accept the patient and bring them in, and the transport process. And it may simply be that there isn't an open bed in a suitable inpatient environment for this patient yet, so they have to wait for somebody to discharge or a room to be cleaned, etc. So the boarding problem is really common. It is frequently attempted to be addressed by opening a boarding area, a unit that has lower acuity. By definition, these patients are stable enough to be observed in an inpatient bed. These are not critical care patients, typically speaking. If they are and the ICU is full, the ED is capable of providing ICU level care in most cases, but that's a different challenge. But there are a lot of patients that are not in need of critical care, but do need to be observed in the hospital overnight or perhaps for a longer period of time. And those patients can be observed in a lower acuity environment in a boarding area with nursing coverage and typically either physician's assistant or nurse practitioner coverage, what we call an advanced practice provider, or perhaps an attending physician or a fellow. So this allows the hospital to decant those patients into this environment, provide them with appropriate care in case of decompensation, and enable those vacated exam room areas to be used for treating new patients. And the third challenge that I wanted to look at today, and all of these, as you can probably already tell, are deeply interrelated, is waiting room congestion. Waiting room congestion occurs when the ED cannot bring patients back to rooms fast enough, and the ED waiting area begins to become overcrowded. So this is slightly different than true ED crowding because it can happen even when there's open treatment areas in the emergency department because of lack of staffing or some other kind of flow failure. Typically, though, it is a consequence of crowding. And ED over congestion is a real problem for a number of reasons. First of all, patients in the ED are not getting medical eyes on them frequently enough. Patients are typically given routine vitals by nurses who will patrol the ED when there's crowding. They will even send physicians sometimes into the ED when there's severe crowding, but they are not receiving the level of care that they would receive if they were back in the emergency department itself. And this is a real problem for two fundamental reasons. First, waiting room decompensation can result in patient death in the waiting room. This is a massive problem. Obviously, a patient has died. That's the biggest problem. Second of all, there are liability issues associated with the hospital for that. And the other factor that waiting room congestion drives is leaving without being seen or leaving before care has been completed. And that is catastrophic for the hospital. It's catastrophic for the patient because we know that patients who leave without being seen, so you're sick, you go to the ED, you look at the waiting room, you go, oh, this is going to take too long. I'm just going to go home. It's not worth it. Those patients are just as sick as patients who are actually seen in the ED. And so patients will leave without being seen, even though they're having a heart attack, even though they're having a stroke. And there's obviously no care that can be provided if the patient. So these are the three fundamental things that emergency department leaders have come to me asking me to help with. I've been able to address all of these issues in the past using the tools that I can bring: the discrete event simulation, the modeling of the system, the validation of the model, and then the use of that model to test addressing change, to test improvements that can be made in the system, to determine the value of hiring additional staff and the return on investment for that, the financial viability, and the minimization of risk and the minimization of left without being seen. So there's a lot that we can do to address these problems. I don't want this to just be a, hey, there's a lot of problems. There are a lot of problems, but there's also a lot of ways to address them. And I am an expert in doing precisely that. And so I hope that you have found today's discussion of these challenges a little bit enlightening. And if you are interested in how to solve them, that'll be the next video. I will talk with you soon. YouTube thinks you're going to like this right here. And I would love it if you would like and subscribe and press all those various buttons that you have access to on your screen, because that will help my channel out quite a little bit. Thanks a lot. Bye.